Alright, so we just went over the tachycardia algorithm, so now let's kind of go over some of the rhythms, the different tachycardias that you might see. And the first one is, of course, sinus tach, which is defined as anything greater than 100 beats per minute and is estimated to have a maximum of 220 minus the age. So in a 40-year-old person, that max would be 180. Generally, you don't see it going that fast for sinus tach. If there is, if you do have sinus tach, treat the underlying cause, whether it's anxiety or pain or hypotension or fever or whatever. The next tachycardias we're going to look at are reentrant tachycardias, or SVTs, supraventricular tachycardias. And they're called supraventricular because they originate above the ventricles. So if this is the SA node and that's the AV node, traditionally, of course, this is the pacemaker of the heart. It sends signal down to here. The signal comes through there and goes through the various bundles and goes across the heart. With a reentrant tachycardia, you have signal that comes down through here, but then it comes back up through here. And so then you get this cycle going as the signal re-enters the atrium and then comes back down again like this, and so you get this cycle, and then that tends to cause a fast heart rate. Since the downward part usually involves the QRS, you're going to see that it's going to use this conduction system to propagate electrical activity to the rest of the heart, and so you'll see a narrow complex. So let's take a closer look at this reentrant cycle. So here's the SA node. The AV node. So with one kind, the one path comes through the AV node and the other path goes outside the AV node. So one path is through the AV node, and this is what we call an AVRT. AV reentrant tachycardia. And the other one has one path coming in the AV node and the other path going back up the AV node. So here, the reentrant tissue is in the AV node. And we call this AV nodal reentrant tachycardia because the reentrant tissue is in the AV node. These two tachycardias are what we used to call SVT, or PSVT, which is paroxysmal supraventricular tachycardia, which means that this would start paroxysmally or just suddenly start, and then you'd get this big cycle of tachycardia, whether it's from an AVRT or an AVNRT, with heart rates usually exceeding 150 and going up to close to 200 sometimes. And these could easily be extinguished by anything that would slow conduction through the AV node and thereby breaking one path of this cycle. And so vagal maneuvers would frequently work well here. Now contrast that with a reentrant cycle that is entirely outside of the AV node. Vagal maneuvers, which would slow down conduction through the AV node, would have no effect in this kind of loop. And so if vagal maneuvers didn't work, the other thing you could do is give drugs that would block the AV node, so AV nodal blockers. And those are the things we mentioned earlier, like adenosine, beta blockers, and calcium channel blockers. They would break one, or in this case, both limbs of the cycle, and thereby terminating the cycle. Now, of course, in this one, an AV nodal blocker is not going to work. The next kind of tachycardias we'll look at are the autonomic tachycardias. And these are one in which there is not necessarily a cycle causing the tachycardia, but some autonomic tissue, pacemaker cells doing it. So again, the normal way that electrical activity would progress is it would start in the SA node, come down to the AV node, and then propagate through these. And when this fired and caused the atria to depolarize, you would get your P wave, and then of course this would cause your QRS. But what if you had some other tissue acting as the pacemaker and causing signals to propagate through here, and it could happen fast? such as an ectopic atrial focus. Whereas here you would see the P, Q, R, S, T. With this one, the electrical activity is starting somewhere else, so that P wave is going to look different. So it might be upside down or have some other different morphology. We'll call that P prime here. Well, what if instead of having one ectopic focus, you had several? And so each one could fire. And so you could have a tachycardia because of so many different pacemaker cells going. And this would be a multifocal atrial tachycardia. And so each one of these things would have its own P wave shape. So maybe this one would be like that. And then the other one would be kind of like that. And another one might like look like that. And since each one of these is firing at its own rhythm, you're going to notice that this is going to be irregular, whereas the other ones would be regular because it's one set of pacemaker cells firing. This one is separate ones firing, each one at their own rhythm, so you would get an irregular rhythm. And finally, the last pacemaker cell that could fire and cause a tachycardia is if it comes from the junction itself, the AV node, and that's called a junctional tachycardia. And since there's nothing firing over here, you're not going to have any P waves at all. It'll just look like that. And excuse my drawing, but that should look regular. And since each one of these now is coming through the AV node, you would expect that our AV nodal blockers should work here as well.